I'm delighted that you could join us today for this, our second webinar from the International Collaborative for Best Care for the Dying Person. My name is Professor John Ellershaw from the University of Liverpool, and I am the chair of the Executive Committee of the International Collaborative. I'll say a few more words about the Collaborative in a second, but just to introduce you to the programme for this next hour. Our first speaker, Professor Mark Bowie, who is Clinical Lead for Palliative Care for the Victorian Centres of Clinical Excellence and Director of Palliative Medicine at St Vincent's Hospital, Melbourne, Australia. So Mark will be leading us off, talking about steps to demystifying dying, recognition, the key to responding. Our second speaker is Dr. Seamus Coyle. Seamus is a little bit more local to me than Mark, and Seamus is a consultant in palliative medicine at the Clatterbridge Cancer Centre in Liverpool and honorary senior clinical lecturer at the University of Liverpool. And Seamus is going to share with us some exciting new basic science work that he's been undertaking over the past years around the biology of dying and can we predict the dying process. And finally, to introduce Dr. Jet van Esch. Jet is from Erasmus Medical Centre, Rotterdam, Netherlands. She's an elderly care specialist working in Hospice Lawrence, Cadenza, Rotterdam. And Jet is going to report the findings of a study called the Silence Study, looking at the prophylactic treatment of death rattle. So I think we have a very impressive lineup of speakers. I'm looking forward to hearing from all of them, and I hope you enjoy the webinar. A little bit about the International Collaborative before we start. Our collaborative is a membership collaborative. We have 126 members from 21 countries around the globe. Some of you joining us are already members, but some of you may not be. Our vision is that we want a world where all people experience a good death as an integral part of their individual life, supported by the very best personalized care. So what does the collaborative do? Well, we promote best care for the dying person. At the center of what we do is looking at the key principles and core outcomes of best care for the dying person. And we have a model for care plans for dying patients and a formal process, a 10-step implementation process for the care plan. This has been adapted and implemented in a number of regions and countries around the world. And to support that model of best care, we have research and development, some of which you'll hear about today, quality assurance, a quality improvement framework to underpin the 1040 model, and an active learning and teaching program, of which this webinar is part of it. So, can we demystify dying? I'm now going to hand over to the speakers, but please use the chat function to ask any questions, which I'll pick up at the end of the presentations. We're expecting each talk to take about 15 minutes. So let me introduce you now to Professor Mark Bowie. Mark, over to you.
Thank you. I'll just share my screen. If you come off yours, John, that'd be great. And I'll just see if I can find my presentation. Here we go. Something should be happening. Okay, great. Look, thank you. And look, thank you, John, for the introduction. And thank you again for the opportunity to be speaking again in the webinar series. So thank you. I think it's really important, obviously, that as with birth, dying is a profound experience. And it's a profound experience for everyone. Obviously, the person who is going through the process of coming to the end of their life, but also to those that are supporting and caregivers, but also to those that are also the healthcare practitioners and workers working with people as they move through the process. If I was to tell you about an experience I had just in the last couple of weeks of an 87-year-old lady who was already in the hospital network system, 4 or 5 hospitals making up the network, and it was one of the smaller hospitals where somebody had to be transferred. It was recognised that she was deteriorating and that dying was now an inevitable transition rather than a possibility. And the planning had gone ahead to transfer her to the more specialised palliative care or hospice unit because of symptom issues and so forth. But it was interesting at the time of transfer, when the ambulance arrived to take the person to the other facility, that indeed the person had deteriorated. But at this circumstance, none of the staff in their usual care processes recognised the fact that this deterioration was a rapid deterioration and the person was actually dying as they went about their business and transferred the patient. So the ambulance officers picked her up, the ambulance officers took her to the road, on the road, and indeed she continued to deteriorate and died in transit from the hospital to the palliative care unit. So in many ways, not only did people not recognise that the person was dying, or if they did recognise, nobody took the time or opportunity to respond to that change. It then left the paramedics, the ambulance officers, who did recognise that she was deteriorating and dying, but they felt unempowered to make any difference, that the process of transfer had to occur, and that was their job, rather than to look at saying, no, this person should really be in the same hospital they'd come from. And they were traumatised. Not only was the family traumatised, the staff were traumatised. And so again, even in this day and age of our reshaping healthcare, of fantastic opportunities to provide good end-of-life care and to recognise these situations, still we are finding in well-developed systems the lost ability to recognise when somebody is dying, but then being empowered to respond and to take that opportunity to really work in this space so that people do and can receive the care they're expecting around that really fundamentally important time of dying. In many ways, it's an opportunity, I guess, that we continually come back to this issue and point of why is dying seen to be so difficult? And we can all speculate on the sort of healthcare reasons why people are reticent to recognise, but reticent to respond even if they do recognise. How families, even with the cultural overlays and the other sort of nuancing of the dying process, it's so difficult for people to then sometimes know how to respond. So today is really to help us to understand that we're trying to sort of reclaim the importance of recognition, but the importance of taking the opportunity as healthcare practitioners to really stand up and advocate for a structured and a recognised response to that process, because the impact for people can, for the families that are left, the caregivers and staff, end up being lifelong issues of difficult and complex grief. It's also interesting to know that there is a strong public desire, even though people think about cultural issues and issues of faith and communication and that sort of reticence to discuss these things, the public opinion really is very strong. They really do fundamentally want to know and understand what is going on, even though there may be a reluctance and a resistance. To recognise that at any stage in anyone's illness trajectory, transitions of advancing disease, deterioration, function, frailty, and symptom issues can point to maybe dying being a possibility or becoming a probability, but then at some point becoming an inevitability. I was fascinated in the last couple of years. I've had a lot of opportunities to speak in our Australian press around this issue. And in fact, it's interesting in our main press and in one of our federal care help websites that these are the 2 most requested articles. One is in the Sydney Morning Herald, which people may or may not know about what happens as we die. And one is around care for the dying person in one of the web series on Carer Help Network. And they're the most requested and downloaded pages. And fundamentally, it really is just spelling out and trying to demystify the essence of what dying may or may not may look like. And I've been in situations where I've been doing ward rounds and people have, say, recognised the name and said, "Oh, you're the person that wrote that article. You're the person I've given it to all my friends in our community group." And said, knowing that has really helped us to understand fundamentally what is going on. Why haven't the clinicians, why haven't the doctors spoken so frankly and so openly about these issues? Also, I think it's important to recognise that people have, such as the International Collaborative, taken steps to try and develop care plans for a dying person, pertinent and relevant to the local community, to the country or the state, to make sure that people can understand what those fundamental parts of the planning are all about. But you need to fundamentally recognise that somebody's dying to be able to then start a care plan that is able to help the transitional part of the inevitability of dying to be understood by the staff that are working with the patient and the family, but also to the family members and to the patient themselves in that recognition and how important that can be. I think this then raises the next question of, if we are in that space of wanting to recognise and respond, we do have a responsibility. In fact, every healthcare professional should have a responsibility and feel that they have the right to escalate and to advocate and to rattle the can to say, this person we think in this situation looks like they're dying. Now, we obviously have had situations where that may or may not necessarily be the case, but for the majority of people, it's bringing together that expertise and clinical picture of seeing a deterioration, of understanding trajectories of illness and understanding fundamentally the look of people as somebody moves towards dying. And I think it's important that as those transitions change from the probability to the possibility to the probability, the inevitability of dying, we need to understand what those important things are in the last days and hours of life. But we also need to understand that and articulate that dying has, for this person and this family and the caregivers and so forth, become inevitable, in a sense that even though we may be alleviating symptoms, or we might be helping to maybe continue some hydration and those sorts of things, that really the dying is going to be inevitable no matter what our interventions are going to be. But we're trying to help make the transitions as comfortable and as smooth, I feel, so seamless for those that are witnessing as well as for the person going through it. I think there is a real responsibility of not only recognising, but a challenge and a responsibility for us as healthcare professionals to raise this with the person and those that give the care, if indeed this is part of their complexity of the social setups and the sort of cultural nuancing obviously being taken into consideration in this sort of space. And I think what's important is just understanding what is the information that's expected towards and during and after death. What are the things that are important to the family and caregivers, to the patient at the time as they're moving through this transition, but also to the family after, as death is approaching, but also then what needs to be looked at after death in terms of arrangements and grief and loss and confirmation of death and those sorts of things. So what do we look for? Look, I'm sure if I was to ask you to raise hands and nominate the signs and symptoms of a deteriorating dying patient, you would say, that's easy. I know, I can tell you. And many of you are very experienced clinicians who would understand this, but it is quite alarming at times, as I mentioned in that case at the beginning, that this was a recent situation where capable healthcare professionals didn't take the time to check a patient prior to transfer. And then at time of transfer, the paramedics didn't feel empowered to raise the issue. They felt they were just part of an inevitable process of moving somebody in the system. And you can all imagine how different that dying would have been if that situation had been recognised, tactfully communicated to the family that the plans had changed, but then cared for the person at their original hospital around that dying time. In fact, it really was within an hour or two of just that transfer process being initiated. So in the last days and weeks of life, I think it's important to understand the signs and symptoms that we see. And obviously these are quite common, and in many ways the time and opportunity isn't here to unpack them, but we're looking at the person, we're looking at the changing situation, we're looking at the things that have shifted, the capacity of what they're doing and the interactions that they're taking. And again, the experience of clinicians to help lead this is often important. But we should recognise that most healthcare professionals, certainly as they're moving into more senior levels, should have some understanding around these things. And often in our situation, it's often our allied health in terms of physios and OTs that are often the first people to nuance that function is starting to change, when maybe at sometimes we haven't recognised some of the other symptoms. So of course, we're going to look at the history of progression of a life-limiting illness. We're looking at the declining physical function. And that could be something in comparison to something 2 or 3 weeks ago, or a conversation with the family to say how things have changed or shifted. The increased time in bed and that tendency to be sleeping more times than awake. So people measure functionality scores, and often it's a reflection of time in and out of bed, or time in bed, but how often they're asleep and the duration of that sleep during the day. Often we talk about that increasing disinterest of food and fluid, and that's often a very important part to the family and sometimes the patient as well, but particularly the family, in that shift and change, which is important to take an opportunity to express and discuss with the family why this is happening, and to actually look at the inevitability of dying as an important part of the process, not just to be reactive to maybe some of the concerns, but to be able to try and walk people through that particular process. And again, we know that shift in the ability to swallow medications, and we all know the transitions where people's medication needs diminish, but also that the shift in orals to subcutaneous or other delivery methods of giving medication. And I think in many ways we're looking at a situation where those decisions to manage symptoms without restoration, we're not looking for restorative care, we're looking for maybe stability or good management or symptom relief, but we're not looking to turn back things to try and manage symptoms in a way that's going to bring people away from that sense of inevitability. And in many ways, we're also at that point where we're starting to rely on others to be part of the decision-making process, that the time that the person themselves, although they still may be fully capable right up until the last few minutes and hours of life sometimes, but we're often relying on others who have been nominated to be part of that decision-making process. If we skip then to the last hours of life, and again, these are things that I'm sure if we were to go around the group tonight, you'd be well versed, but it's important that these are the things that are missed. And this is the situation with this person in the ambulance transfer, that really this was actually actively happening in many ways as the people were being moved from the bed into the paramedics' care to take from the hospital. A sense of progressive and extreme drowsiness, that sense of changing consciousness. Maybe the increasing confusion or delirium, the delirium at end of life, is becoming more apparent. It may not be assertively aggressive or agitated, but the sort of restlessness that people see as life comes to an end at times. And that then translates, again, if it is a little bit more extreme, into that sense of restlessness and possible agitation that again needs explanation and discussion. So it's often good to have those explanations in recognising dying. It's good to have the explanations and the change so families understand this, if indeed it does occur at this time. And we talk about the noisy breathing, we talk about hyperpharyngeal secretions, which we're going to talk about a little later, but these are things that we all, and families, expect it. They expect that at some point there's going to be something around the breathing and possibly as sort of the rattling sounds that people get as dying is moving into this space. And again, the difficulty of slowing breathing and so forth, which again is very common in these processes. And again, things that you've noticed that people should notice in that clinical context, families have often noticed that they're not weeing as much, that there maybe there's been incontinence, but potentially the retention of urine at that time. And again, we see the changes that you see in terms of the way circulation is working and so forth. So these are all very straightforward things that we all anticipate, we know about, but it seems to be that if we don't recognise these patterns, we can't begin the conversations and earnestly advocate when people look like they're on a trajectory where maybe people are still focusing on elements of perfusion, elements of taking bloods. We've all seen situations where we recognise dying and somebody's still down for a CT scan to do a sort of restaging and so forth. It needs somebody to step in and say, we feel at this stage that things are shifting and changing. So really to say thank you, really a very quick introduction, but really to wave the flag to say the importance of recognition. So you can have all the processes in the world, you can have all the tick boxes in the world to say looks like this person is dying, but unless somebody recognises it and is able to step up and then respond in an appropriate way. And it's a two-part process in many ways. It's empowering people. We empower people and healthcare professionals, we empower carers to escalate when there's a sudden deterioration on the ward, on an acute medical ward or at home. We call the 000, but we still need to take that same sort of sense of urgency if somebody is deteriorating and dying and people aren't there, the family aren't ready, the family may not be at the bedside, or all those sorts of things that you see play out. And really it's a sliding door approach, isn't it? So often when we reflect on a difficult dying, often the difficult dying is that process of deterioration without regard to earlier recognition and meaningful discussions with the family at that time. So thank you. I might finish there and hand over to Seamus. So thank you, Seamus. I'll just finish sharing my screen.
Thank you, Mark. So, Joe, you're going to get, thank you, Joe. So my talk is the biology of dying and can we predict the dying process? So this is what I'm passionate about. Thank you, John, for inviting me to speak. Next slide, please. So accurately recognizing when someone is in the last days of life is difficult. And I like to think of palliative care professionals, we're pretty good at it. But every now and again, we get caught out and it's difficult, especially with the younger patients. But as an example, the National Care of the Dying audit in hospitals in the UK. So over 200 hospitals participated in 2019. And they found that the median time that somebody was recognized to be dying, that death was imminent, was 36 hours, so a day and a half. So you reach 80 years of age and you're finally recognized to be dying a day and a half before you die. That's terrible. But for 20% of people in the entire UK, it was within 8 hours. So 20% of people died within 8 hours of it being recognized. Half of all of those people didn't have capacity to join in any meaningful conversation. And yet a third of people died in a bay with multiple other people in at the same time. So, it's not easy for our fellow clinicians to recognize when people are dying. And anything, I think, is an improvement on 8 hours and definitely the last day and a half. But nobody knows if a dying process exists. So, Mark just said, well, we can see that look. But there isn't any that's known. And it's difficult then to demystify dying if you don't know what, so you can demystify dying in terms of symptoms and signs, especially for the public, but then to try and demystify it from a kind of a basic science point of view, well, we don't know what's going on. Then I think it's harder to demystify. So the next slide. So actually, how do we die? Autopsy results will tell us, well, actually, most people will die from a pneumonia. Well, how do you die from a pneumonia? Nobody knows. So if you drown, for example, carbon dioxide will build up in your lungs. Carbon dioxide then goes into your bloodstream, and it makes the serum of the blood acidic. So just like a can of Coke, you put carbon dioxide in it and it makes it acidic. When it's acidic, it kicks calcium off the proteins that bind it. Calcium then goes to the heart, that free ionized calcium goes to the heart, and you get an arrhythmia. That's how you die from drowning. But you say, well, how do you die from pneumonia? Don't know. And about 50% of people with cancer, on an autopsy result, they'll say, well, an infection was the main cause of death. 79% of people on autopsy with cancer will have some element of a bronchopneumonia on board. And others will say, well, it's advanced cancer or PE, but PE in 10% of people, I don't see people dying suddenly from a saddle embolus in my clinical practice. So next slide. What I've done in the past with my team is, we've done a systematic review of biomarkers of dying, but there's no single clear biomarker of prognosis in palliative care patients. What it shows is that, there's systemic inflammation. So CRP goes up, but it will go up in an infection. It will go up with your cancer. There's organ dysfunction, but not failure. So you'll get renal dysfunction, but it won't be renal failure. You'll get liver dysfunction, but not liver failure. And you get cachexia. Yeah, the albumin goes down, but actually we don't know how you die from cachexia. And Paul Taylor with Miriam Johnson, they've done work in looking at all of the vitals and bloods of people, and they've showed, well, looking at all of this, there's some renal dysfunction, and then people will get short of breath. So there's some deranged respiratory function as well. So next slide. So we've taken a completely different approach. We've kind of taken what's called a metabolomics approach. So you kind of go, let's have a look at every single metabolite that we can see in urine and see what that can tell us. So in this particular study that I'm describing, we took 112 people who had lung cancer. They were all inpatients. They were in a hospice or they were in a hospital. We didn't care if they thought to be dying or not, just that they were an inpatient and we could get their urine. And then in retrospect, we found out when they died, and then we could say, oh, well, that urine sample was more than 3 months away from dying. That urine sample was 4 weeks away from dying, and so on. So, and we collected, samples from 45 women and 65 men. And the majority of them had an adenocarcinoma, non-small cell, but it was an adenocarcinoma. Then after that, it was a squamous cell carcinoma. And then 22 had a small cell lung carcinoma. And then we took people with a radiological diagnosis of lung cancer. So there was only 15. Some had a clinical diagnosis of lung cancer, and then 3 had a mesothelioma. And the age range was from 47 to 89, but the median was 7 to 1. And we collected approximately 60 samples in the last 4 weeks of life alone. And so what do we do with that urine? What do you do with it? Well, you go to a machine that costs about £250,000, and they put it through chromatography. It separates out all of the metabolites, and then a mass spec, and then that kind of tells us what that metabolite is. So it can tell us, oh, these are such and such an amino acid, glucose or other sugars, various hormones, various things that say, to relate it to diet. Basically all of the metabolites that are in our blood that go into the urine. So next slide. So, and from those hundreds of metabolites that we identified, we could see those that were significant in the last weeks of life. So I've written down volcano plots. So there's a way of looking at hundreds and thousands of genes or proteins and metabolites, and to see what's significant from within all of that. And that's one of the omics statistics ways of looking at statistically significant compounds. And we did standard analysis of variance to see, well, what chemicals change in the last weeks of life. And we've done something called a Cox-Lassus regression analysis. Basically, when you look at all of those, we've identified a number of metabolites, over 100. And that tells us a bit about the process of dying in the last weeks and in the days of life. And taking some of those metabolites, we did this Cox-Lassus regression analysis. And I don't know how to explain it properly. A statistician has told me what to do. But out of that regression analysis, you can come up with a model, a urine model, and it says this will predict for the last 90 days of life. So that's what the Cox-Lassus did for us. And we've done it for 90 days, and we've done it for 30 days, and right up to 10 days and 5 days. And I'm going to present the 90 days next. So next slide, please, Joe. This is what's called a Kaplan-Meier graph. So if you look at the x-axis down at the very bottom, you'll see 10, 20, 30, all the way to 1900. So that's basically the days, the number of days that someone lives. And then on the y-axis, it says overall survival probability. So one is 100% chance of survival. At 0.5, that means that 50% of people will have died. So looking at the very top line, there's a light blue line at the very top. And you can see that that pretty much stays at 100% for almost till 70 days. So you go all the way across, come down, and you can see that hits around 60 to 70 days. So from our urine, you put it through the machine, we identified some of the metabolites, we can get this risk score. And from that risk score, you can say, well, actually, these people will be alive in over 2 months' time. And at the other end of the other extreme, those with the highest risk, well, you can say, you go, well, actually, at least more than 50% of people will die within the next week, and that everyone will die within 3 weeks, within that risk. So next slide. And we can do that with approximately 88% accuracy. So the graph on the left shows the area under the curve. And that, anytime you have a test and you want to see how good it is, so PSA they use for prostate cancer is not very good, and it's got an accuracy of about 65%. And then if you go with a clinician, so the best score for recognizing dying 2 weeks away from dying is a MDT discussion. And that's about 85% accurate, 2 weeks out. So, but we're getting close on almost 90% accuracy for every single day of the last 90 days of life. And then, the score on the graph on the right shows our mean and the median, which is the blue line. A 95% confidence interval is this dark gray that you can barely see. And then our maximum and minimum is the light blue that's on top. The next slide, please. And this is the same score, or another model that predicts the last 10 days of life. If you look at the right-hand graph, you'll see that gray line at the top. Well, you can definitely say from the urine just alone, you say, well, that person's not in the last 10 days of life. And then the blue line, you say, well, actually, more than 50% of people are going to die within the next 10 days. And again, that has an accuracy of almost 90%. So next slide. So in conclusion, I think from my basic biology research and some of the stuff that I know that we're going to publish later in the year after we get a patent in August. But, we believe that there's a process to dying, and as we discover the biology of that process, we can better inform the care of those towards the end of life. So next slide. In particular, I'd like to acknowledge Ellie Chapman. She's the lady with the graduation gown, and I haven't acknowledged Andrew Davison and Brendan Norman. But I have now. So I'm going to hand over to Jet Van Esch, and she's going to introduce the silence study.
Well, hello. I hope I can be heard, and I can't put my camera on. Yes, I can, I guess. Can I be heard?
Yes, loud and clear, Jet.
Okay, but can I? Yes, and I have my video on, so I can start sharing my screen. Wat moet ik hier? Oh jee. Dit niet. Just a moment, please, because I want to share my screen and I can't seem to get it right. I think this is wrong. Joe, can you help me, please?
Yeah, would you like me to share your slides, Jet?
Yes, please. I'm very sorry, but
no problem.
It's not. I'm not a technicus. I'm a doctor. Well, while we're waiting for the screen, and there's my presentation, I will first begin with to thank the International Collaborative for the Best Care of the Dying Person for inviting me for this webinar. I'm Jet, and as told, I'm an elderly care specialist working in a hospice in Rotterdam in the Netherlands. And in this hospice, among other hospices, this study was conducted. Because for years there is discussion if death rattle, a symptom of dying, should or could be treated. We were intrigued by the question if treatment was possible and therefore designed the silence study. Scopolamine butyl bromide given prophylactically for death rattle, a double-blind, randomized, controlled, multi-center trial, and I will share with you the results of this study. Can I have the next slide, please? First, for some context, some background information. Death rattle is a sign that death is very close, about hours away, and the unpleasant noise is caused by accumulated fluids in the throat, which cannot be coughed or swallowed away due to diminished consciousness. Death rattle is scored by the scale of Beck, and 0 is no rattle, 1 is audible close to the patient, 2 is an audible rattle standing at the end of the bed, and 3 is an audible rattle standing in the door opening. And in a recent study, 61% of the dying patients developed death rattle, most on a moderate to severe level, which are scores of 2 or 3. Relatives experienced death rattle as very stressful and expressed a great need for better care in case of this symptom. They associated death rattle with drowning and unworthy dying. We found the same in our own research. Information and communication are not enough for relieving experiences of the relatives. Can I have the next slide, please? So should we treat this symptom? Patients seem not to be hindered by it, and the burden is on the relatives. So it's proper to doubt if you should treat the patient when he doesn't have any complaints, because treatment can cause adverse events. And with anticholinergics, it's a dry mouth, urinary retention, and restlessness, and those can hinder the last moments of life. Patients who have earlier experiences with death rattle are often afraid of it and associate the sound with drowning. However, in the Netherlands, we assume that patients do not experience this symptom That's what we tell the relatives. And in cases where that rattle is severe and family is stressed by it, we treat the patients with anticholinergic drugs like scopolamine butyl bromide. These medications diminish the mucus production. And the efficacy of those drugs was studied earlier. We found 2 double-blind placebo-controlled trials in literature. Both were performed when that rattle already existed, and both found no differences in the effect on that rattle or on adverse events. Likar used scopolamine hydrobromide in a small group of 31 patients, and Heisler used atropine but administered only once. A larger observational study by Will Deers compared 3 regularly used medications for that rattle and also found no differences in efficacy nor adverse events, but it didn't incorporate a placebo arm. And when we look at how the medication works, preventing mucus production and not mucus removal, it's understandable that these findings were not significant because all earlier studies gave the medication when that already existed. So what if we gave these drugs prophylactically? And we found one randomized controlled trial from 2018 which showed results that were in favor of prophylactic use of scopolamine butyl bromide to prevent this symptom. The most important comment on this study is that this research is not a double-blind placebo-controlled trial. And as you treat patients who possibly won't develop that rattle, and as adverse events of this medication, as I told you already, dry mouth, urinary retention, and restlessness can occur, it's the question if it's ethical to give this medication to all patients in the dying phase. Can I have the next slide? An RCT is the only way to determine if medication is effective and if it's safe to administer. And the co-production of Erasmus MC and 4 hospices designed, conducted and finished an RCT, namely scopolamine butyl bromide, given prophylactically for that rattle, the SILENCE study. And this study was sponsored by ZonMW. Can I have the next slide, please? After admission, eligibility was checked and the patient was informed, and after 84 hours of reflection, the patient could sign an informed consent when he wishes to participate. Can you click, please? The inclusion criteria were a life expectancy of at least 3 days, awareness that admission was up to death, and the patient should be able to understand information given about the study. When the dying phase was recognized, exclusion criteria were evaluated again. Can you click again? And when the patient used systematic anticholinergic drugs or octreotide, or had that rattle grade 1 or high at the start of the dying phase, or an active respiratory infection, this patient was excluded. Study medication was randomized and given every 6 hours from the moment we recognized the dying phase. And the care program of the dying, in short, the CPD, started. The CPD was also used for recording adverse events and death rattle scores. Can I have the next slide, please? Primary endpoint was the percentage of patients who would develop death rattle, defined as the occurrence of death rattle with a severity of grade 2 or higher, according to the scale of Beck at 2 consecutive measurements at an interval of 4 hours. Secondary endpoints and other endpoints included the time from the recognition of the dying phase until the occurrence of death rattle in hours, the occurrence of adverse events of anticholinergics, and those were assessed through the CPD every 4 hours. Other secondary endpoints are named here on the slide. Can I have the next slide, please? And now for the results. From April 2017 until the end of December 2019, the hospices admitted 1,079 patients, of which 626 met the inclusion criteria. 533 were asked to participate, and from them 229 signed the informed consent. Randomized were 162 patients, and eventually 175 patients were analyzed, 97 in the scopolamine butyl group and 87 in the placebo group. Can I have the next slide, please? The baseline characteristics are well balanced across the groups. Men and women were equally divided, and the median age of the patients in the scopolamine butyl group was 87, where it was 75 years in the placebo group. Among all patients, 80% had cancer, and COPD and coronary heart diseases were the most frequent comorbidities. Can you click, please? In the placebo group, we found there were more patients with lung cancer. Can you click again? COPD as comorbidity. Can you click again? And a history of smoking in the previous year. I come back onto these findings later on. Can I have the next slide? A significantly higher percentage of patients developed death rattle in the placebo group compared to the scopolamine butyl group. Can you click? A p-value of 0.002. Next slide, please. This slide shows the risk of death rattle. This was also significantly lower in the scopolamine butyl group, the red line. Click, please. We found there are no significant differences. Can you click? In the occurrences of adverse events between the treatment groups. The quality of the last 3 days of life was rated significantly higher by the attending nurses. And we found that the patients in the scopolamine butyl group significantly lived longer after the recognition of the dying phase. Click, please. We did a post-hoc analysis where we looked at the subgroups lung cancer, COPD as comorbidity, and a history of smoking in the previous year in the placebo group because this could influence the results. However, we found that the occurrences of death rattle in those groups were lower, 11, 17, and 50% than in the entire placebo group. Next slide, please. We performed a sub-study and sent questionnaires to relatives 3 months after their death. And we asked them the questions about their experience and meaning of participation of their loved ones in research. We asked them questions about perceived burden or stress of such participation for the relative, the patients, or for other family on a 4-point Likert scale. And in the results, we found that 85% felt no burden or stress in relation to participation. And 87% found this research very, very, very valuable. Can I have the next slide, please? And a click. The silent study proved that the prophylactically given scopolamine butyl bromide is effective for reducing death rattle in the dying phase with a significantly higher quality of life in their final 3 days compared to patients who received placebo. Click, please. Also, no adverse events of scopolamine butyl bromide seem to influence the dying phase. And we found a longer dying phase in patients who received scopolamine butyl bromide. And the meaning of this finding needs further to be researched. Although this was an exploratory outcome, this finding is consistent with the previous reported randomized trial I named in the beginning from 2018. Next slide, please. One of the strengths of this study is that it's the first RCT of this magnitude at end of life performed in hospices and shows that large-scale RCTs are possible in the dying phase without a burden for the relatives. This study has also some limitations, and one of the limitations could be that the recognition of the dying phase was based on criteria in the Dutch guidelines and on the experience of healthcare professionals. We didn't use a tool because there is none. And this may have resulted in various interpretations of recognizing the dying phase. Another limitation may be that only 10% of the admitted population was included in the final analysis. A large group dropped out due to their vulnerable state. We do not expect that these patients had a different risk of death rattle compared to the participating patients. Thus, these results may be applicable to a larger patient population. The next slide, please. And to conclude, I can tell you that prophylactically given scopolamine butyl bromide after recognition of the dying phase reduces the risk of death rattle and does not seem to induce adverse events. A randomized double-blind placebo-controlled trial performed in the dying phase in hospice settings is possible, and more research is needed to provide evidence-based treatment at the end of life. And for my last slide, I would like to thank all the patients, click please, relatives and healthcare professionals who made this study possible and a success. We thank Zon and Wei for their sponsoring, and this study couldn't be done without all my co-researchers here on the slide. I thank you for your attention, and I give back the word to John.
Thank you, Jet and Seamus and Mark, for your presentations. I shall just share my... No. Joe, maybe you can put the concluding slides up for me.
Yep, just 1 second.
Yeah, thank you for the presentations. We have, there's a question here about what is Zon MW, Jet, please.
I was already typing. Zon and Wei is a collaboration which supports funding for research among this in palliative care.
And also, Jet, has this changed clinical practice now amongst the clinicians that you've done this study with?
Among the clinicians, I do not know. I'm still very now cautious about it because we haven't had in the Netherlands the discussion yet if this should be practice and in what way you should implement these results. So
okay. We've got a question from Tanya about what dose and application way was used for the scopolamine.
We gave scopolamine butyl bromide 20 milligrams and we gave it subcutaneously. 4 times a day.
Okay, thank you. And Seamus, are you behind your screen? He is?
I am. Sorry.
I am, you are. Seamus, just tell us a little bit about the metabolites that you are using in the predictive models. Are these kind of expected metabolites or from pathways we recognize or you'd expect with a kind of a dying organism?
I think, so without going into specific metabolites, I think there's a few surprises in there. And then in the sense that, you know, dying is one of the major physiological processes going on during life. And I suppose some of the metabolites that we see, and what, you know, you can definitely see from urine, for example, that a person is eating less. You can see that they're taking less green veg. You can see that they're taking less aspirin, for example. And, you know, taking less drinks. And, you know, when we did a subgroup analysis, you know, on people who are on 10 mg of midazolam or levodopa 25, you could actually see, for example, that caffeine is possibly a cause of agitation, low caffeine. So people are going through caffeine withdrawal. And then other metabolites that are got to do with hormones and then and various other pathways within the body. Yeah. Does that answer your question?
Yeah, I think it'll be interesting to hear more into the future about how these pathways and where these metabolites fit into the various pathways. Yeah. And maybe back to Mark. Are you there, Mark?
I am. I think Joe's got control of my video screen.
She's
so,
okay. We can hear you, even if Joe won't let us see you. But no, there you are. You're back now.
Okay, great.
Just about the diagnosing dying and recognizing dying, I guess one of the big areas we've worked hard on in the UK is about particularly medical undergraduate education and teaching our doctors of the future about what dying looks like and how to manage and care for dying patients. Is that the same in Australia? And how do you promote that within your medical schools?
Look, certainly I think there's been a lot more emphasis. I mean, I think in our particular university, the University of Melbourne, people get a 2-week exposure in their 4th year of a postgraduate course, as well as emphasis across, across illness trajectories in the first 2 or 3 years. And certainly that's a very important component. I guess the shift and change comes in the hierarchy when people are moving into clinical practice, that often the more junior you are, the less likely you are to maybe raise or question the work that's going on of more senior, and obviously depending on what sort of units you're working on. So I think even though the training is improving, and I absolutely do think people are more able to raise and communicate, it really comes down to many ways the culture and the sort of imperatives of the units that they're working on that can influence their ability to be the ones, because often they are the eyes and ears. And particularly if you haven't got a strength in the nursing or allied health componentry of a unit, or, the people who've got strong nurse leaders and strong allied health were more likely to be able to articulate these things in sort of meeting processes or urgency of care. But I think things are shifting and changing. It's just that I think the dynamics of hospital services continue to play out in a more traditional way.
Okay, thanks. I'm just aware of the time, and we'll move to a few concluding slides. And if the speakers can just keep an eye on the chat and answer any further questions. So next slide, please, Joe. So that's been a fascinating hour, but what's next? So next slide. Well, I think for the members, the slides and the talks from today will be now on the members site for the International Collaborative. For those of you who aren't members and are interested in what we do and how we do things, do visit our website. The address is there. If you Google Best Care for the Dying, it comes up in the first few hits. To be a member, you have to be a healthcare professional or an active researcher in the field of care for the dying and end-of-life care. So please do join us. Next slide, Joe. And if you do join us, you can participate and be involved in some of the major international research projects to improve care for the dying. We've just concluded a big international research program between Europe and South America, looking at bereaved relatives' experiences. And we're currently involved with 13 countries in the collaborative, with an EU Horizon 2020 program, looking at a cohort study with 2 embedded studies around volunteering in palliative care and appropriate prescribing towards the end of life. And we'll be sharing some of those findings in our webinar later in the year, which will be in November. So some of the other membership benefits are listed there. So please do visit the site, have a look at that. It will be great to have you as part of our community. We have a summer school and annual symposium each year. They've had to be postponed this year, but we indeed hope to hold them next year. Summer school in Malaga in May and our annual symposium in October in Liverpool. The next slide, Joe. And finally, just to advertise our next webinar, where we're going to talk more about our 1040 model of care and 2 examples from around the world, one from Argentina and one from India. So if you're interested in the care plan and how we implement that in different healthcare settings in different continents, please come and join us on the 16th of September at the same time. And you can register for that in the same way as you did this time on our website. And please do encourage other people who you think would be interested in that. So thank you once again to all our speakers and to all our participants. And we hope to continue communicating with our membership, welcome new members, and hopefully welcome you all back in September. Goodbye for now. Bye.
Goodbye, and thank you.
Bye, everybody.
Thank you.